journalist in New York who talks a lot about education, and I'm sure she's getting sick of getting tweets from me. Okay, let's go back to our first story. Thousands of people in England have had do not resuscitate orders imposed on them without their family's knowledge. This is according to an audit of dying patients. 1 in 5 families were not consulted where doctors decided not to revive their relative. This is according to a sample study by the Royal College of Physicians. Let's talk now to Rita Powell, who's on the line. Rita, you are Dr. Rita Powell.
I am, yes.
Yeah.
No, not a GP. I was actually a psychiatrist in my heyday,
Right.
but and a junior doctor, and a whistleblower. So in '98, I whistleblew on this subject actually.
Right.
So,
tell us why, because it was a big thing to do. You ended up leaving practice because of it, didn't you?
Well, yes, I ended up leaving the medical profession, but that's another story. But the more important issue is in 1998, I was obviously a very junior doctor, and I discovered that DNR notices were arbitrarily placed because doctors were too busy, relatives weren't there, discussions couldn't, take place. But in those days, the guidelines weren't, perfect. And after the publicity for the DNR and age concern in the year 2000, the BMA and the RCN released the guidance which you have now. But the problem with just releasing guidance and not actually doing audits and looking at the patient safety aspect is that things actually don't improve. All right. I mean,
what did you find when you did your whistleblowing? What was it that was concerning you?
Well, basically, people who there's a difference between dying and being very ill. All right, and the distinction is very, very, important. And I was finding that people were just written off and just placed on DNR. I think the problem with DNR is that nursing staff think, okay, from DNR, you don't have to feed them, you don't have to do, you don't have to take care of them, and they don't get their, fluid intake, etc. And of course, people die like that. And I think DNR notices are appropriate in obviously certain patients, but there's a criteria to. Doctors know what the criteria is. You assess the prognosis. You talk to the relatives. You agree the quality of life isn't good, the prognosis isn't good, and the resuscitation would fail if that's the case. But in the cases that I've seen, people were placed on DNR notices, and no active treatment was given when they were ill. I mean, I treated a lady, which is she was in the media at that point in time because I whistleblew about that case, and every doctor had given up on her. And unfortunately, I couldn't call the crash team or anything like that. I had to just quietly try to take care of her, and I did take care of her. And she was an ill patient with pneumonia, but she was a tough cookie, and she survived. She survived and went home. She was actually 80.
She had a DNR notice.
She did, yes. She had a DNR notice on her.
So, although you hadn't have been there, and she had a term for the word, she wouldn't have been resuscitated.
No, she wouldn't have been resuscitated. No, and I think if she'd collapsed, they wouldn't have called the resuscitation team in, and she would have died, much earlier. But I think that sometimes people, health professionals. Can be quick to judge, and I think the training of junior doctors is quite poor in this area, unfortunately. Now, doctors are often quite good at managing patients. It's just that, the situation we have at the moment is very similar to the situation in '98. We are under-resourced, short-staffed, and actually a lot of studies have shown that the NHS is discriminatory, both elderly discriminatory and disabled discriminatory. So when you have those combinations, a study like the one the RCP has done, well, we call it an audit, is actually, what they're saying is that there are problems in the practice of DNR. But what they haven't said is, what is the patient safety aspect of this? How many were wrongly applied? All right, so there's a distinction. Now, in 16 years, they could have done a patient safety profile of who was actually...
How much of that kind of information is available to do that kind of an audit to say, after the event, it seems that the DNR was wrongly applied? That's quite difficult to decipher, isn't it?
Well, I think in legal cases, experts have to decide whether a patient could have lived, could not have lived, whether there was a good prospect that resuscitation could have worked. For instance, if a person's, blood tests are great and they just deteriorated very acutely and a DNR was rapidly placed on them, it could be ruled that actually a DNR notice shouldn't have been placed and a resuscitation may have been viable. Now, CPR has a low prospect of success. Now, everybody knows that. It's also quite traumatic. But the issue is, in practice, now I've been to resuscitation, right, and a lot of people have lived. A lot of people have died. But it just depends on the patient on that day at that time. So you can't actually, the research is all well and good, but, you've got the patient, and you can't always apply research to the patient in front of you. That's my point. And
and I know you said that you felt that parts of the NHS were discriminatory against the elderly and against disabled
people. Well, it's not just me who says it. It's actually the leading study that was done in 2009 by the DH themselves, so Department of Health themselves, and it was ruled. Their findings were that the NHS was institutionally ageist, and of course there's MENCAP's report, I think it's death by indifference, which describes the fact that they feel that the NHS is discriminatory towards disabled people. So the problem with that,
can you tell us what is it like when you are in a situation like that on the ward, and what it's a clinical decision, as I learnt last year. I don't know if you heard me talking about my dad, but we were
unfortunately,
to go away and think about it, and obviously it's an incredibly stressful situation.
Yeah.
And then we agonised over it, only to be told, well, actually, it's a clinical decision. So in that clinical decision, in that meeting, how does that work for those of us that don't know? But can you paint us a picture?
Well, they're normally called MDT, so they're sort of team meetings, and ideally the relatives should be brought in, and the senior doctor should discuss the prognosis of the patient. The patient, of the patient or relatives or whoever they want in the meeting. And in that meeting, they ought to, the senior doctor ought to discuss prognosis, quality of life, and all these sort of things. And the relatives and the patients are obviously the best people to tell the consultant or the senior doctor, what kind of quality of life the patient has always had. Yeah. And it's really a two-way thing, and that's how it should happen. In practice,
in your experience,
but in my experience, but in practice, right, half the MDTs don't happen because senior doctors are very busy. Your registrar isn't available. No one's really available, and it's up to the junior doctor to try and make the best decision they can on the phone by ringing one of the senior doctors and writing the decision down, which is not good practice, but that is exactly what used to happen. And so registrars who had never seen the patient before, late one night comes and has a quick look at the records and puts DNR down, because obviously it's late at night. You don't want to call the resuscitation team in. The person's elderly. The blood test
people listening to this, Dr. Paul, they'd be terrified thinking,
I know.
someone is making a decision based on barely knowing the patient, barely having spoken to anyone, and looking at a few stats on a chart.
Well, the continuity of care used to be better before the MMC came along, but with shift systems, the continuity of care has gone down, unfortunately, and that is well known within the medical fraternity. And I think that's something that the Department of Health needs to discuss. And I think that the junior doctors have always talked about continuity of care and the importance of patient safety, and part of the strikes that are going on at the moment is the importance of patient safety. And I think historically the Department of Health has made it impossible really to have proper discussions with relatives, to have the time to do that, to have good protocols. The guidance that are issued are really wishy-washy. The BMA is the trade union.
In your view, is that at the heart of it? Is that the guidance is because if I look at what NHS England has said, they said a spokesperson from NHS England said, "We welcome the results of this audit, which we commissioned, and which show there has been some improvement in the care provided, but there is clearly more that can be done. Although this audit presents a snapshot of end-of-life care within NHS hospitals, there are clear variations in the support and services received across hospitals and areas where improvement must continue to be made." Now, those variations, is that, do you think, down to different interpretation of the guidance?
I would say the guidance isn't robust enough. The guidance is done by the BMA, which is our trade union, and also the RCN. The GMC really needs to take a lead, and so does the RCP. It's done this audit now, but the General Medical Council is the head of education, really, practically. It is the leader of the medical profession, and it needs to take the lead. And when I raised the issue with them at the time, they didn't want to address the ageism in the NHS. They didn't want to address the DNR issue. So there is no leadership with this issue, and there is no issue about patient. We need to consider patient safety. Where is Mike Durkin, the czar of patient safety, in this in this matter. I mean, he should be saying, we've done this audit, we've got this backdrop of the NHS. I mean, how safe are these DNRs to these patients? He needs to be asking that. And also, this has implications on the Liverpool Care Pathway, which, as you know, was very controversial, and the DH did a review on it a couple of years ago. So it has implications, wider implications. And I think that, I mean, the audit is it's great. They've come up with a few conclusions, but the variations really is down to, who people employ, staffing levels, a resource, and of course clinical guidance and leadership, really. So that's my summary.
And can I ask you, when you first talked about this topic publicly, when you did the whistleblowing, what was the response to you from your fellow medical professionals?
Well, obviously antagonism, and I think that's understandable because no one really likes to be told the real story in the NHS. And I think people felt I was speaking against the medical profession, and that's not the case at all. I'm really speaking about the Department of Health and the relevant health ministers during those periods, and it's been 16 years who have failed to take this DNR issue and take it seriously. Really, there's been a number of court cases about this, and you don't need court cases to have safe practice. Really, you need to be able to deal with the situation when someone raises it. The important thing is not what happened to me, it's what happened to a lot of patients. And I think that if you look at the death rate, the mortality rate of the NHS, it is high. Look at the discrimination, it is high. We need to be providing good care for the people who are most vulnerable, which is the elderly, who have worked very hard to actually make England a good place, and also the disabled. And I think that if we're not providing good care and DNR notices and other issues, right, if we're not providing good care for these patients, then the Department of Health is failing. And I think that, this DNR study probably shows that the Department of Health is failing in its continuity of care and all the aspects I've discussed.
Well, thank you for talking to us, Dr. Rita. Thank you, Dr. Rita Powell there. If some of what you are hearing resonates.
Thank you, Doctor.